السلام عليكم ورحمة الله وبركاته. This is Mahmoud El-Rosasy, Professor of Orthopedic Surgery, Tanta University. I'm presenting our technique for distal femur realignment osteotomy by open wedge osteotomy using a simplified external fixation technique. Angular deformities of the distal femur can occur due to can be acquired or developmental and are seen in patients with fracture malunion, distal femur growth disturbances, or metabolic bone disorders. Varus and valgus deformities of the knee increase medial and lateral load respectively. This theoretically could facilitate the progression of osteoarthritis. So the benefits of early femoral osteotic fluid realignment: it reduces the symptoms and may prevent joint degeneration before arthritic changes and restoration of the normal alignment. In patients with arthritis, often can decrease pain and improve function and slow further degeneration, even in the future if the patient needed to have joint replacement. The restoration of the mechanical axis should facilitate insertion of joint arthroplasty. After doing the osteotomy, it comes the question how to fix the osteotomy. Actually, and in the literature, there is little to suggest choosing one fixation method over the other for fixation of the distal femoral osteotomy. In the preoperative evaluation, we do X-ray standing scanogram for mechanical axis deviation and the location of the site of the deformity, the coronal, and the magnitude of the deformity and the plane of the deformity. So we define the magnitude of the deformity by the mechanical axis deviation test, and where a neutral alignment is the goal, never overcorrect, especially in adolescence. Don't forget to answer the 10 questions of the 10 commandments of deformity correction we have postulated before. In a case of distal femur valgus deformity, we draw the joint orientation line and locate the site of the cora by drawing the mechanical axis or the anatomical axis of the distal femur and the required or the needed mechanical axis or anatomical axis. So the cora is in most cases actually is located intraepiphyseal. Practically, we can never do the osteotomy intraepiphyseal. So we have to do metaphyseal osteotomy. So we have to do osteotomy rule 2. Doing osteotomy rule 2, we have to do some translation of the distal fragment. The amount of the translation depends on how much or how far we do the osteotomy from the site of the core. Doing osteotomy rule 2, so you have to rotate the distal fragment. So how to define or to detect the direction of rotation of the distal fragment? Always think of deformity correction as circle. The circle, the middle of the circle or the center of the circle is a cora, which is a center of rotation of the angulation. So we rotate the distal fragment around the center of this circle. So in this cases of valgus, we rotate the distal fragment laterally. So the distal fragment will translate laterally. In case of varus, distal fragment will rotate medially. So it will translate medially. But in our osteotomy technique, we have the hinge, where the bone rotates around is located on the medial cortex. So we have a virtual hinge located in the medial cortex. So in doing the osteotomy, we have to maintain integrity of the medial cortical hinge to avoid displacement and to increase stability of our construct. So this drawing and this graph, we can imagine together how the osteotomy will open and how the correction is done. So we do what's called a circular distraction. So the center of the deformity and the center of the cora, or or the virtual hinge in the center of the cora. We do the osteotomy. Please imagine the red circle and the yellow circle. The yellow circle with all the distraction along the yellow circle is the distractor. Distraction along the red circle is the hinge. So distraction in the distractor is faster, goes faster than the distraction in the hinge. You can see here the hinge does not displace and the circular distraction will produce the correction. In this graph, we can see the correction doing the circular distraction. In this case of bilateral genovalgus, due to distal femoral valgus deformity after doing X-ray standing scanogram, intraoperatively, we draw that this is a patella, the joint orientation line, mechanical axis of the femur. So the lateral distal femoral angle is 75 degrees bilaterally. So we need 15 degrees of acute correction. Intraoperatively, we start by insertion of a reference wire, which is parallel to the joint orientation line of the femur. This wire should be just above, located intraepiphyseal, just above the Blumensatz's line. We should never violate the Blumensatz's line to avoid intra-articular insertion of the pins. This wire will be removed by the end of the procedure. Then we insert our first pin, which is metaphyseal, just proximal to the physis to avoid physeal injury. In this case, we insert this pin slightly posterior so that the next pin will be slightly anterior. So we have triangulation of the pins to increase stiffness and stability of our frame using the least number of pins. Remember always that in the femur, we insert the distal pins parallel to the joint orientation line. However, the proximal pins are inserted perpendicular to the anatomical axis because if you try to insert them perpendicular to the mechanical axis, then it's technically difficult and you will have your pins at oblique in oblique direction on the femur. So we insert them perpendicular to the anatomical axis, and at the end, the pins will not be parallel to each other, the proximal and distal pins. This is our frame. It is a simple frame formed of two Ilizarov arches, two Ilizarov hinges attached peripherally in the location number 1, and two central distractors in the location number 2. This is the frame, completed the frame. During application of the frame, we start with the hinges and leave the insertion, the attachment of the distractors after completion of the frame application and after doing the osteotomy, and then we attach the distractor and to effect the instrumented deformity correction. We can see here, you see the line of the mechanical axis of the femur. The pins are not perpendicular to the mechanical axis, but rather perpendicular to the anatomical axis of the femur, and the hinges should be overlaying each other. And we maintain a distance between the arch and the skin to avoid abutment of the frame against the skin. After application or insertion of the pins and the attachment of the frame, we do percutaneous osteotomy through 1 cm skin incision, multiple drill holes, and complete the osteotomy by an osteotome. During doing the osteotomy, we try to maintain integrity of the medial cortical hinge, which will be used to maintain bone contact and stability of our construct. Then we start the instrument, attach the distractors, and start the instrumented controlled deformity correction by circular distraction. Instrumented controlled acute deformity correction. And check after the correction the lateral view to detect any unwanted displacement. After completion of the procedure, we do full knee flexion to split the iliotibial tract by the pins to avoid post-operative stiffness of the knee. Follow-up scanogram to ensure that the correction is the desired correction is acquired. However, in cases of if needed fine-tuning of correction in case of over or under correction, we can use the distractors to do fine-tuning of the deformity correction. This is a follow-up. The patient can, after 2 or 3 weeks, usually can stand up and start assisted walking. We remove the frame after full bone consolidation and after the patient is able to do the single leg stance test described by us and published before. In adolescents, the frame usually is removed after about 3 months, exactly 90 days. No cast is needed after frame removal. It can be removed as an outpatient procedure under intravenous sedation anesthesia. This is a case of 28 years old male who had kidney transplantation and on anti-rejection treatment. He had bilateral genovalgum deformity and right spastic hemiplegia. So we did for him left side correction by our technique. He's happy with the left side. However, he had DVT, and luckily enough he was treated and came after 1 year to correct the right side, which is a spastic side. Intraoperatively after correction, we can check the accuracy of our correction using the long threaded rod technique. We prefer to use a long thread rod formed of 2 or 3 thread rods connected to each other by thread sockets rather than the diathermy cord, because the diathermy cord is pliable and can be deceiving. We prefer using the long thread rod technique. So from the center of the femoral head to the center of the ankle joint, the rod should be crossing the center of the knee joint. As we see here, we always maintain the medial cortical contact. After 3 weeks post-operatively, there is adequate bone contact to maintain the correction. The patient started weight bearing. This is another case of hypophosphatemic rickets. For fear of poor bone formation, we choose in this case to do gradual deformity correction, and it was achieved by the same technique. Another case of Ollier disease. He has varus deformity with leg shortening. We apply a stronger frame, the same concept, but in this case, due to the need for femoral lengthening, we prefer to use 2 arches proximally and 2 arches distally, acute correction, and subsequent lengthening with very nice bone formation and lengthening of about 4 centimeters. Another case of wind-swept deformity. We used our simplified techniques for both the femur and the tibia. And, the outcome of our technique, we achieved the restoration of the mechanical axis to within the normal range. The knee range of motion is limited during treatment to 90 degrees due to fixation or during fixation due to tethering of the iliotibial tract by the half pins. However, it was restored after removal of the frame and intensive physiotherapy. At follow-up, the knee range of motion was similar to the pre-operative range of motion. We observed no cases of non-union, no deep infection. In one case, the patient developed DVT and pulmonary embolism after 35 days of bilateral distal femoral osteotomy in an adult. That's why I stopped doing bilateral distal femoral osteotomy in adults. I prefer to do, after this case, I prefer to do 1 leg at a time in adults. In young adolescents, lightweight, we can do bilateral osteotomy, but in adults, I never do bilateral osteotomy in the same time. In one case, who had kidney transplant, he had DVT, which was treated successfully. The post-operative pain site care was maintained by the patient after our instructions how to take care of the pins. None of the patients had residual deformity or leg length discrepancy. The distal femoral osteotomy with a unilateral Ilizarov arch fixator is entirely a percutaneous procedure. There is a less risk of primary or secondary loss of correction. Stability of the construct allows early mobilization and even weight bearing. Limitation of near range of motion due to tethering of the iliotibial tract remains to be a treatment related problem. Thank you.